10 seconds.
Over to you, sir.
Yeah. Good evening, friends. This is Dr. Rajkumar. On behalf of IPS Vadodara branch and Bombay Psychiatric Society, I welcome you to this web series, Brain on Wednesdays. And the topic for the day is understanding prolactin. All of us have to face this situation time and again in our clinical practice, and many a times are at wonders what is going on and how do we manage this prolactin issue. There is none other than Vaibhavi who is going to take us through understanding prolactin in a better way. I welcome my co-moderator Rukshida to take over.
ಇದಾಗ್ತಾಗ ಇದನ್ನ ಒತ್ತಿದ್ರೆ ಬರುತ್ತಲ್ವಾ ಈಗ ಬೇಡ ಬಿಡು ಈಗ ಬೇಡ ಅವ್ರೇನು ಮಾಡ್ತಿದ್ದಾರೆ
Good evening, everyone. Like Dr. Rajkumar said, I'm Dr. Sayeda Rukshida. I have the honor and privilege of being the president of Bombay Psychiatric Society. And on behalf of the entire EC of BPS and members of BPS, I am happy to associate with this ongoing series, which is curated and moderated and so very well and under the able guidance of Dr. Rajkumar, Dr. Malay Dave, and Dr. Bhaskar Mukherjee. So BPS is happy to be associated with this series, and today being the first of the episodes that BPS has aligned with IPS Vadodara, it marks a special occasion for me and BPS, and we welcome all of you all today for this special session. And I'm really happy to introduce the speaker for today. Like Dr. Rajkumar said, none other than Dr. Vaibhavi. Dr. Vaibhavi is an assistant professor at Mandya, Karnataka, but more than that, she's worked with me for a number of years now. She's part of the editorial team of the newsletter of Indian Association of Biological Psychiatry. The newsletters are a monthly series that goes out, and she puts in a lot of effort. And even if you just with one glance of the newsletter, you know that her keen interest in biological psychiatry, her keen interest in liaison psychiatry is so very well reflected there as well. She's a good speaker. She's a very sincere, efficient person, and I'm sure that we learn a lot from her on this topic today. And with this, I'm going to hand it over to Vaibhavi and request her to start her presentation.
Good evening, everyone. Thank you so much, ma'am, for the introduction. Must thank Brain on Wednesday series hosted by IPS Vadodara, and also would like to thank Dr. Rajkumar sir. Let me just share the screen. I hope I'm audible aptly. Yes, thank you. Right, is the slides fine?
Yes, the slides are fine.
Yeah,
right.
No problem.
So I would like to thank my moderator, Dr. Malay sir, as well, and Dr. Bhaskar Mukherjee. So yes, let's start with the topic. I will begin with understanding prolactin. Was a very nice the topic name given by Dr. Rajkumar sir. So I would like to begin with the prolactin hormone per se, the physiology of it. Then we will discuss a little bit on hyperprolactinemia and also a note on hypoprolactinemia. Right. So as we all know, prolactin hormone was firstly way back sort of studied way back in 1928 by Stretcher and Greta. So they found a lactogenic effect which was found while injecting the anterior pituitary extracts into the castrated virgin rabbits. So eventually it was named as prolactin because of the action it had, and in 1933 by Riddle and colleagues. So prolactin has been shown to have more than 300 actions, including metabolic, fluid and immune regulation, reproduction, which is a major action, and also various other endocrine, autocrine, and paracrine activities. Coming to the molecule per se, it is a 23 kilodalton polypeptide hormone, which consists of around 199 amino acid, which is synthesized in the lactotrope cells of the anterior pituitary gland. In humans, the prolactin is coded by chromosome 6, and it consists of 6 exons and 4 introns. So it also has a 3D structure which comprises of 4 anti-parallel alpha helices, and it has a strong structural homology which mimics that of growth hormone and also placental hormone or placental lactogen. So it is usually secreted in a pulsatile way, and it can increase during sleep, stress, food ingestion, pregnancy, chest wall stimulation, and even trauma. Of course, there are a lot of lists which we will be discussing later on. So the prolactin usually is found in a free form, that is the monomeric prolactin, what we refer to as. So as I'm showing here, it's the monomeric prolactin here, which is weighing around 23 kilodalton, and it's usually the active form and present around 60 to 90% of the serum prolactin levels what we measure. Then we have the big prolactin, which is basically a dimeric form, and it consists around 15 to 30%, which can vary. And the third isoform of prolactin, what I'm referring here, is a big prolactin, which is basically a complex structure which includes the prolactin aggregates along with the IgG immunoglobulins. So it is usually variable, and it's usually the inactive form like the dimeric form, and it can vary in presence between 0 to 2% or even up to 8%. So among the hyperprolactinemia, the presence of big prolactin, which is referred to as macroprolactin, can consist of around 10 to 46% of the macroprolactinemia. So there is a particular method where we can find assess this, that is through immunoassays, and usually it is a gel filtration chromatography, which is the gold standard. But the cheaper version and which is easily accessible is the PEG, that is polyethylene glycol precipitation, which we use to differentiate between the free prolactin and the macroprolactin. Coming to the receptor, it is usually coded on chromosome 5 as respect to the prolactin hormone per se, which is coded by chromosome 6. It comprises of the 3 units, that is the extracellular domain, a single transmembrane domain, and an intracellular signal transducing domain. So in addition to this, prolactin, the human prolactin receptor can also bind to the placental lactogen and growth hormone, since I've discussed that it is structurally homologous to these two the hormones and the placental lactogen. Binding of ligand can happen usually at the extracellular sites, usually when it is pre-dimerized, and it can trigger the series of signal transduction events. And these events are usually through signaling either through JAK-STAT pathway or SRC family, that is tyrosine kinases, and also phosphatidyl inositol pathways and MAPK, and even serine and threonine kinases pathway. However, would like to mention that these receptors are not only restricted to pituitary origin, it can also be found in the extra pituitary sites like mammary tissue, testes, prostate, seminal vesicles, adipose tissue, liver, etc. So coming to the regulation, so mainly the prolactin is regulated by dopaminergic neurons. The dopaminergic neurons are further classified into 3, that is tubuloinfundibular, then we have the tuberohypophyseal, and we have the periventricular hypophyseal dopaminergic neurons. So of this, though all the 3 types of dopaminergic neurons exert the action on the prolactin secretion, the tuberoinfundibular neurons arise from the they tend to have a little more robust the effect on the prolactin, and it usually arises from the dorsomedial arcuate nucleus, and they can project into the external zone of the medial eminence, like you can appreciate here, which is mainly this site for the lactotropes, I mean the prolactin secreting cells. And finally, it can lead to spontaneous firing, and it can also lead to a state called as upstate. So the point to remember here is the tuberoinfundibular neurons, which have an effect on the prolactin. So here I've gone on to just depict it pictorially, where you can appreciate the dopaminergic neurons which have an inhibitory control on the prolactin release. So even the suckling stimulus basically sends ascending signals, the impulses to the dopaminergic neurons, and it inhibits the dopaminergic control over the prolactin. Basically, it disinhibits the dopaminergic control, and finally it leads to increase in the prolactin release. The other stimulatory uh, other inhibitory the signals and the factors are I have listed here. Basically serotonin, noradrenaline, histamine, opioids, somatostatin, even cholecystokinin, then GABA, estrogen also have an inhibitory effect on the dopaminergic neurons, and thus the prolactin release can be found to be elevated. And the stimulatory ones on the dopaminergic neurons are acetylcholine, oxytocin, vasopressin, which also bring about the contrary effect on the prolactin release. So the lactotropes are the only anterior pituitary cells that can display spontaneous electrical activity in the absence of hypothalamic stimulation. So although hypothalamo-prolactin lacks the classical anterior pituitary hormone, which has a negative feedback pathway, it does account to some amount of negative feedback, but it's not the main pathway. However, dopamine itself is a main regulatory factor for the lactotrope proliferation, as well as also aids in the suppression of estradiol induced proliferation. So dopamine has a three-layer system of control. So firstly, it inhibits the calcium influx, which is mainly required for prolactin secretion. So by inhibiting the calcium reflux, it can lead to membrane hyperpolarization and finally leads to prolactin secretion. It also suppresses the adenine cyclase, thereby inhibiting the prolactin gene expression itself. So the other second thing is it brings about prolactin regulation of dopamine neurons is mediated by multiple mechanisms, which is usually spread across time courses. So it usually has a rapid component and a delayed component. So prolactin can be rapidly increasing the firing rate of these neurons to induce the increased dopamine secretion, and it also can bring about rapid suppression of further prolactin secretion from the lactotropes. And the slow phase where there could be prolonged changes in the tyrosine hydroxylase phosphorylation. And finally, the transcriptional events can also regulate the dopamine production and secretion over a much longer time course. So basically, dopamine forms the robust regulatory mechanism over prolactin secretion. Coming to the biological functions of prolactin, so we can further classify as lactotropic functions, reproductive, its effect on the other hormones, immunologic system, and others. So lactotropic functions mainly, as we all aware, it stimulates the mammary gland growth, along with estrogen, progesterone, placental lactogen, insulin, and cortisol. Mainly, which I'm referring here is the pregnant females, and it prepares the breast for the postpartum lactation. As we and postpartum phase, the suckling reflex maintains this regulation and increases the prolactin by suppressing the dopaminergic neurons. In the reproductive effect, it basically modulates the axis via there's something called a KISS gene, and in turn can lead to decreased LH-FSH ratio, finally leading to infertility. Other effects could be on glucose homeostasis, also affect on dehydroepiandrosterone, cortisol, and aldosterone secretion by the adrenal cortex. And effects on immunological system, it itself can act as a cytokine. It is also produced by lymphocytes and other immune cells. It also takes part in osmoregulation, proliferation, differentiation, and migration of neuronal stem cells. Myelination of CNS also is a part of this function. So another slide which actually shows the extrapituitary actions of prolactin. Apart from the lactation and reproduction, it can also lead to tumorigenesis. It also acts on the pancreatic islet cells. So during the pregnancy, it can lead to increased beta cell mass, increased beta cell replication. Glucose stimulated insulin secretions also triggered during pregnancy, which is part of the physiological role. While it also acts on adipose, and it can also bring about increased fat storage, and also acts on immune cells, which can lead to T cell activation and proliferation. Pathologically, when all of these act on these pancreatic cells or adipocytes, it can lead to gestational diabetes, or it can have a role in obesity, or it can also have a possible role in autoimmune diseases like multiple sclerosis and SLE. So these are some of the metabolic effects of hyperprolactinemia, which have depicted here. So excessive prolactin can also act on the pancreas, small bowel, liver, and also adipose tissue. And each of it can increase the action, and also can lead to excessive adipose and also fat accumulation. So coming to hyperprolactinemia per se. So it refers to an increase in circulating prolactin levels, usually producing reproductive problems in both sexes, particularly anovulatory infertility, which is prevalent in women. So estimates of prevalence has been reported as approximately 0.4% in unselected normal population, 5% in a family planning clinic population, and also 17% in women with reproductive disorders. So these are the prolactin levels which are usually seen on the testing. That is, males usually normal levels could be between 2 to 18 nanogram per ml, whereas the females it can range between 2 to 30. But normally, when we check the fasting serum prolactin levels, anything above 5 nanogram per ml would be normal in males, and usually females tend to have more than 20 to 25. Coming to the peak of prolactin secretion is usually appreciated in pregnancy. That would be in third trimester, and it can range anywhere between 10 to 210 nanogram per ml, and it can also peak to 600 nanogram per ml postpartum. While drug-induced can also lead to elevation of serum prolactin to above 200 nanogram per ml in case of risperidone and metoclopramide. And of course, prolactinomas are wherein it can be definitely raised about 200 and more than 500 can be diagnostic of macroprolactinoma. Some of the main causes of or the major causes of hyperprolactinemia can be classified as follows. So let me talk about the physiological causes, mainly pregnancy, as there is increase in the serum prolactin itself, and also it is conjugated with the action of the estrogen. Then is in postpartum, there could be nipple stimulation, lactation also can lead to increase in serum prolactin. Exercise, stress, even post seizure, there could be elevation in serum prolactin. Usually post seizure, there could be a minor increase in the serum prolactin ranging up to 50 nanogram per ml. Other reasons for physiological could be sleep, neonatal period, or even sexual intercourse can alter the values. Pathological conditions can be further divided into pituitary disease and hypothalamic disease. In pituitary disease, we usually come across prolactinoma, acromegaly, Cushing's disease, macroadenomas, or there could be some pluri-hormonal adenomas, lymphocytic hypophysitis, and paracellular mass, or even macroprolactinemia. Coming to the hypothalamic disease stalk damage, it could be tumors, it could be granulomas, it could be infiltrative disease like histiocytosis, it could be Radke's cyst, or it could be even pituitary stalk transection secondary to a head trauma or cellular surgery. And cranial irradiation also tend to increase the serum prolactin levels. Next, the third will be the pharmacological causes. Here I've listed the general pharmacological agents which can alter hormones, being estrogen therapy and thyrotropin releasing hormone. And as against the dopaminergic control, which inhibits the prolactin release, thyroid releasing hormone has a positive, that is, it stimulates the prolactin release. Next, coming to the anticonvulsants, phenytoin, and some anti-hypertensives, mainly the calcium channel blockers like verapamil, and other drugs like methyl dopa and labetalol also tend to increase the serum prolactin level. And coming to H2, that is a histaminic antihistaminics, that is H2 receptor blockers. So cimetidine and ranitidine, opioid analgesics like methadone, morphine, apomorphine, heroin. Cholinergic agents also tend to alter like physostigmine. Coming to the psychotropic induced hyperprolactinemia, first generation definitely will lead to their potent dopamine receptor blocker. So we will have an increase in the incidence when referring to first generation. So chlorpromazine, fluphenazine, and haloperidol. Second generation antipsychotics, which are also can lead to hyperprolactinemia, including paliperidone, risperidone, quetiapine, amisulpride. Other D2 receptor antagonists like metoclopramide and domperidone can also add to the increase in the serum prolactin levels in certain patients. Antidepressants also are tend to add to the increase in the serum prolactin levels like amitriptyline, desipramine, clomipramine, and also fluoxetine. There have been many case reports regarding this. So monoamine oxidase inhibitors like paraglin and chlorgeline also have been reported. So the next cause, apart from the pathological, physiological, and drug-induced, is the systemic disorders, which can lead to hyperprolactinemia, like chronic renal failure, polycystic ovarian disease, liver cirrhosis, pseudocyesis, reflex causes like chest wall trauma, surgery, or even herpes zoster. Primary hypothyroidism can also lead to serum increase in serum prolactin, Cushing's disease, Addison's disease, and even post epilepsy or seizure. Some of the idiopathic causes could be like wherein there is no other attribution, but there can be incidental finding of a microadenoma which is less than 2 mm. And there is something called the familial idiopathic hyperprolactinemia, which could be caused by germline heterozygous mutation in the prolactin receptor, disrupting the ligand binding, and can lead to downstream signaling, resulting in the prolactin insensitivity. Genetic causes could be inactivating prolactin receptor mutation, and ectopic uh, production could be seen in cases of bronchogenic carcinoma and hypernephromas. So let me just elaborate a little bit on prolactinomas. So the most frequent organic cause of prolactin excess, and it is also the most common hormone secreting pituitary tumors. So they represent approximately 40% of all pituitary tumors, with an estimated prevalence of around 100 per 1 million. So average would be around 100 million 100 per 1 million case, which is very, very rare actually. So the mean prevalence of prolactinoma in gender specific would be 30 per 1 lakh in females and 10 per 1 lakh in men. Prolactinomas are mainly diagnosed in women who generally range between 25 to 34 years, or on a broader range, we can say around 25 to 40 years. So prolactinomas may infrequently be present as a common component of men, that is multiple endocrine neoplasia type 1, when they may seem to be aggressive than the sporadic prolactinomas. In females, it is usually the microadenomas, which are usually less than 10 mm or 1 centimeter in size, than the macroadenomas, while men usually present with macroadenomas. So in general, serum prolactin levels, which parallel the size of tumor size, and they can be over, the prolactin levels could be over 3000 international units per liter, which is 5 times usually than the higher normal values, which are usually diagnostic of prolactinomas. So drugs such as metoclopramide, risperidone, and phenothiazines can also induce prolactin levels much higher at times. And macroadenomas are typically associated with the levels of over 5,000 milli-international units per liter. And in some cases, it could be even more than 20,000. So these values are not absolute, as prolactinomas can present with a variable elevation in prolactin, because there may be a dissociation between the tumor mass and the hormonal secretion. So the first image here depicts a microprolactinoma, while the second image here is suggestive of macroadenoma, which is more than 10 mm or 1 centimeter in size. So coming to the clinical presentation of hyperprolactinemia, usually the suppression is secondary to the, it leads to hypogonadotrophic hypogonadism, which is due to the suppression of pulsatile GnRH or growth hormone releasing gonadotropin releasing hormone. So the clinical presentation can be divided into the two subsections. That is, one could be the secondary to the increase in the serum prolactin levels itself, and the second could be due to the mass effect. So when we talk about signs and symptoms caused by serum prolactin, increased serum prolactin, in females, usually we come across oligomenorrhea, amenorrhea, galactorrhea, decreased libido, infertility, and decreased bone mass. And also, there could be chronic hyperandrogenic signs and symptoms like acne and hirsutism, which is usually common PCOS presentation. And in men, it is usually erectile dysfunction, again, decreased libido, infertility, gynecomastia, decreased bone mass, but rarely galactorrhea. Diminished energy levels, reduced muscle mass, and even increased risk of osteopenia could be seen in both men and women. Talking about the mass effect, it usually presents as headache, which is one of the most common presenting complaint, and also visual disturbances, apart from other symptoms like seizures, hypopituitarism, cerebrospinal fluid rhinorrhea. So just a note on prolactin and infertility. Uh, prolactin as such leads to the decrease in the signaling of GnRH, that is gonadotropin releasing hormone, and finally it can lead to suppression of both LH, that is luteinizing hormone, and FSH, follicular stimulating hormone, and thereby it can lead to decrease in the ovulation, and also eventually in a longer term can lead to loss of ovarian stimulation itself, and these can present as hypogonadism, anovulatory cycles, and it can lead to amenorrhea also and infertility in the long run. And here I put a table which usually grades the symptoms versus the prolactin levels. So usually when the levels are less than 1000 milli international units per liter, they present with decreased libido and infertility. So maybe the ovulation issues, and 1000 to 2000 said to be oligomenoric, and more than 2000 can usually correlate with amenorrhea, hypogonadism, gynecomastia, and even galactorrhea. So let me talk about the management here. So management can be related where we screen for serum prolactin, and here the link here they have used TSH also as a parallel entity to screen the uh, uh, the the pituitary adenomas. So first we need to take a detailed history, whether it is the drug use or any other pathological or physiological conditions, and then we need to check the serum prolactin on 2 to 3 different occasions, and that to a fasting sample. If it is found to be normal, there is nothing to worry about. But if there is an elevated levels, we would check on the TSH level, because in hypothyroidism there could be increase in the serum prolactin levels. So if TSH also is found to be elevated, then there is a way to treat it. That is, we could treat the hypothyroidism, and again we can repeat prolactin after 6 to 12 weeks of regular treatment with thyroxine supplements. And if the TSH level is normal and serum prolactin is elevated, then there is uh, a need to look for further investigations. So it could be an MRI or a CT where we can look for a normal scan. If there is a normal scan and just hyperplasia, then we could just do the empirical management. If there is a microadenoma and a macroadenoma, it could be a mixture of both medical as well as surgical intervention. Here we need to understand one thing. So there is a entity called as true hyperprolactinemia and macroprolactinemia. So in the initial slides where I mentioned that there are 3 isoforms of prolactin, that is the normal prolactin, then there is a big prolactin, and there is a big or the macroprolactin. So the true hyperprolactinemia refers to the increased circulation of the normal monomeric prolactin. So that is the normal presentation, and its majority of the isoform is that. So many a times what happens, if there is an excess of the circulation that is macroprolactin, it can lead to macroprolactinemia, what we call it as. So if we find elevated serum electrolyte, serum prolactin levels on 2 other uh, occasions, then we need to screen for macroprolactinemia, and we need to differentiate from a true hyperprolactinemia. So what do we do is, there is a particular method, like I said, it could be PEG, that is polyethylene glycol precipitation. And with this, we will be able to differentiate whether it is the monomeric form or the complex form, which also has the immunoglobulins attached to it. So once we screen, if it's found to be true hyperprolactinemia, recovery rate is usually more than 40% because it contains majority of the monomeric prolactin. And we also need to exclude, if the physiological causes are excluded, then we can go for imaging. But if you find that there is a elevation of the macroprolactin component, then usually recovery can be less than 40%. And further, we need to classify whether it has elevated serum monomeric form also, or whether it is true macroprolactin. If it is true macroprolactinemia, then there is no further requirement of any um, treatment. While if it is also compounded with the excess of monomeric prolactin on after doing the precipitation, then we need to consider further imaging. The main difference between the true hyperprolactinemia and the macroprolactinemia may not be presenting with a lot of side effects, I mean the presentation which we see in a true case. So macroprolactinemia usually have lower rates of oligomenorrhea and galactorrhea, and it can be attributed to the temporary dissociation of the monomeric prolactin from its immunoglobulin, and so it's usually a transient phase or it could be a short-term increase. So we need not have to worry much about the macroprolactinemia. So here we are talking in respect to psychiatrist what we can do. So before starting any medication, we would take a baseline prolactin level wherever feasible, and we would retest it after 3 months of starting antipsychotic. Just know from the baseline if there is any deviation and we are suspecting in a vulnerable patient. And if it is found to be normal, we don't have to do further blood tests. But if it is found to be abnormal, we need to further see whether it is mild to moderate, whether it is less than 2000 milli international units per liter. And then, but if they're asymptomatic, we will wait and watch. But if they're symptomatic, we will go on to alter the treatment accordingly. But again, if the levels on testing is higher than more than 2000, then we would also consider MRI scan. If it is definitely more than 3000, it could be associated with headache and visual field disturbances like hemianopia. So wherein we would have to either alter the treatment, whether to reduce the offending drug or reduction of the antipsychotic dose, switch to a prolactin sparing antipsychotic, addition of aripiprazole, and it could be treatment with the dopaminergic drug or with estrogen testosterone, and if needed we need to liaison with the endocrinologist. So coming to the management, so we have three groups here. So one is idiopathic or microadenoma associated with hyperprolactinemia. Second one is hyperprolactinemia with macroadenoma. And third one is due to systemic disorders and other pituitary lesions and hypothalamo-pituitary stalk damage. So in first, it is very clear cut. So there is idiopathic cause, and all we have to do is dopamine agonist will be the mainstay of treatment here. This is mainly bromkriptine, and usually the dose is 1.25 milligram per day to 2.5, and it's usually given as a continuous therapy, and we can appreciate the normalization of ovulation and even menstruation after 4 to 8 weeks of the treatment. Other drugs in this is cabergoline and kisspeptin, which has been studied recently. Coming to the second group, here because it is hyperprolactinemia along with the macroadenoma, and there could be some mass effect. Here, the management usually is a combination of both the medical lines as well as surgical lines, along with plus or minus radiotherapy. And usually, the approach is transnasal, transphenoidal microsurgical excisions are preferred. And external radiation therapy comes into picture if if there is a residual tumor and if the surgery is not complete owing to the anatomical complexities. Coming to the third group where there is the systemic disorders, we need to treat the cause here basically, and usually it is 40% of them are associated with the primary hypothyroidism. So correction with the thyroid hormones replacement or supplements is required. And if it is drug induced, we can always stop the offending drug. And of course, it one of the main causes also in chronic renal failure. So correction usually either by mainly by transplant can reverse it, but usually it's one of the elevated parameters in chronic renal failure. So some of the medications listed here are the antipsychotics and their hyperprolactinemia prevalence. Typical antipsychotics do have a good amount of prevalence here, and risperidone and paliperidone can also lead to serum hyperprolactinemia in many occasions. Amisulpride to adding on to it, while olanzapine can be seen usually at the higher doses alone. Quetiapine and clozapine may or may not have or might lead to some transient increase. Azinapine has a questionable role, while aripiprazole is usually said to be the prolactin sparing antipsychotic agent, and lurasidone also tends to have a increasing effect on the serum prolactin. So, what would a psychiatrist usually do when we come across antipsychotic induced symptomatic hyperprolactinemia? So, we either go for a reduction or that is reducing the dose of the offending agent, or we would go for a substitution if depending on the clinical picture, or an addition of a dopamine agonist. And of course, we would intend to liaison with the endocrinologist wherever required, and so we don't miss any of the other macroadenomas and other any worse tumors, anything like that. So they might also introduce hormone replacement, which can be an option. Just note on hyperprolactinemia. So usually it's not much seen as prevalent as hyperprolactinemia. So it is defined as prolactin levels below 3 microgram per liter in women and 5 microgram per liter in men. So some of the causes could be autoimmune causes, hypopituitarism, growth hormone deficiency, hypothyroidism, excess of dopamine secondary to the pathways which can be affected either due to drugs or even other external substances or dopamine receptor agonists. Clinical presentation, hyperprolactinemia is usually associated with ovarian dysfunction in women and men. There could be some metabolic syndrome also. In some cases, anxiety symptoms also have been reported secondary to the decreased serum prolactin, and it can also lead to some amount of sexual dysfunction, either erectile dysfunction, premature ejaculation, oligospermia. In one study, normal sperm characteristics were restored when prolactin levels were brought up to normal values in men with hyperprolactinemia. And hyperprolactinemia can also be a cause for lactation failure post birth. So, when it comes to management, it is usually treating the underlying cause in this case, and those with lactation failure can be fed usually. Can use formula feed, but of course, the alternatives of using metoclopramide have also been studied. And for subfertility, treatment with clomiphene citrate and gonadotropins have also been tried. So I would like to conclude, prolactin is a unique hormone with action at various extrapituitary sites. Categorizing it as a hormone with classic autocrine and paracrine activity is usually critical in pregnancy and lactation, during which the prolactin levels rise and helps in a lot of metabolic adaptations through the cycle of reproduction. Monomeric prolactin is recognized as the biologically active form, and accurate monomeric prolactin secretion concentration measurement is essential for the diagnosis of hyperprolactinemia. So, clinically, prolactin measurement is of particular importance in the evaluation of menstrual irregularities and also infertility treatment in women, and the loss of libido and infertility in men. So, it can also be one of the differential diagnoses when we are dealing with the chronic headaches and also visual field disturbances. So thank you everyone for the opportunity.
Malay, can you chip in now?
Yeah, I mean, anybody can ask questions. We have two moderators. So, Rukshida, your input.
Okay. Well, as usual, Webbewe's done a fantastic job, very comprehensive. And I don't think that any of us, she's given an opportunity for us to ask any questions. Having said that, I think there's a couple where there's one question here. Do you want me to take that, Malay, or will you do?
Yeah, please. Sure.
Right? So I don't know if someone's asking what is the general dose of cabergoline that can be started in psychotropic induced hyperprolactinemia.
I have not used much of this. I would request Malay sir to guide in this case.
I mean, we don't see the thing that happens is that what has happened in my clinical experience is that if there is a slight elevation in prolactin, the gynacs or anybody, they don't advise to do anything. Because first of all, it has to be associated with symptoms. First thing is the level. The second thing is there has to be some symptoms, reproductive symptoms or sexual symptoms or something. Then they will think of adding. So most of my patients, if I find that there is a slight elevation, okay, then I have learned from by referring to gynacs that you just leave it alone. In fact, a patient of mine, the only drug she responds to is olanzapine, somewhere around 10 to 15. And I mean, she has got recurrent psychosis. So I think current episode is third or fourth. And each time I treat, she starts having a little bit of galactoria. And each time now they've understood that something like this happens, get a serum prolactin done. That serum prolactin comes somewhere around 40 or 50 or something like that. So I have referred to her to a gynecologist during the first episode and even the second. So gynec says you just treat. Because this kind of a level is not really problematic, except that that little bit of galactoria is there. So the only thing I do is reduce the dose, and that's about it. It's only when the levels are very high and then there are symptoms, then maybe cabergoline comes in. So they usually start with one tablet twice in a week, and this can be maintained over a period of time. But the most important thing is the level, how much is it, and whether it is causing symptoms. So, and see, most of the time when we just do it and we go by the levels that comes, but there is this issue of macroprolactinemia. We never really think about it. We just get a level and let's do something about it. So, majority of the times the patients are sent back by gynec saying that you don't need to do anything much or anything drastic.
A lot of the times, if I may, especially if the increase in prolactin levels is either borderline or slightly elevated, there may or may not be any symptoms of hyperprolactinemia, but also lifestyle management does make a little bit of a difference. A lot of doesn't really reduce the prolactin too much. But having said that, whatever symptoms there may be, like weight gain or other issues, does get better with it. When there is symptoms, like sometimes the symptoms may not be too much, but they may be distressing. So we might be okay with a little bit of weight gain, acne, and even maybe galactoria and everything. But if it's distressing to the patient, then we would definitely consider starting cabergoline. And again, depending on the level of the cabergoline, either 0.5 once a week or twice a week or something like that. But in cases like this, we do have to constantly keep monitoring, because if they have a propensity of increased levels of prolactin, then that may happen even at a steady dosage. So they may be on a maintenance dosage, and even then the prolactin can go a little up and down, and that can sometimes cause mental health symptoms, like they might feel a little lethargic, or they might not feel like functionality may be impacted a little bit, and that can cause distress, and that's why intervention might be required. But yeah, monitoring is something that will also be important, because you never know when it will get elevated to a level which could be problematic later. There's another question, a clarification Dr. Suresh Kumar is asking is, did you say withholding medications for 48 to 72 hours is enough to rule out drug-induced? I don't think you said that.
Now, usually, if it is drug induced, it will take up to 72 hours for us to withhold, I mean, to discontinue the medication, then we can substitute. But may not be the case, as you have mentioned here. It's not just 48 to 72 hours. We need to see the causal relationship, whether the particular drug is leading to this kind of side effect, and if any positive past history. So usually we would observe and we would substitute in a matter of like it would take 3 days to subside the levels. So 72 hours will be the normal standard for reducing the levels even after stopping the drug, offending drug.
If I may add something, now, we are forgetting that there is a group of patients where anxiety itself would trigger prolactin rise. Number one. Number two, the thing is, there is a very curious relationship between prolactin and estrogen. If estrogen doesn't prime the prolactin receptor, then prolactin effect would not be there. So many a time, in case of thinly built woman who has, you would find this phenotype pretty often. Thin built, mostly they have hyperhidrosis, they have obsessive trait, and they have mildly elevated prolactin level. They don't actually develop any symptoms out of it, but only when they gain weight, the symptom appear, because whenever they gain weight, the estrogen levels actually start rising with the fat, and in them symptoms appear. So there is a group of this kind of women in whom probably we should not do anything except periodically checking the prolactin level, which would be around 40 or 50. They would not show any symptom. And in them, probably withholding antipsychotic would be a problematic thing.
Okay. Uh, so another question that has come is, when do you decide to check prolactin levels? I mean, do you do it regularly for every patient before starting, or do you do it after a certain point in time, or do you wait till some symptoms come up? The symptoms are pretty, I would say the symptoms in women are more clear cut when they miss a period, or they feel, I mean, galactoria or breast engorgement, something like that. Whereas in men, it is not that very clear in terms, because there can be sexual difficulties and all. So, I mean, at what point do you do a test, the first prolactin?
So from a psychiatric perspective, it's ideal to have a baseline. If not, usually once we have introduced an antipsychotic, after 3 months would be the protocol to check on the prolactin levels. And if we are also intending to rapidly escalate the doses, also we could have a suspicion and they're also presenting with related presentations in men and women accordingly, like oligomenorrhea, if not directly, if there is an extension, I mean increasing the period for cycles, and in men it could be other issues like even infertility, apart from that sexual dysfunction. So we can look at this as a part of the follow-up, I believe. And subsequently, if we have a if we have, there is a slight increase and there is still no the clinical side effects, then maybe we can wait and watch. We can, yeah.
Okay. So just in your presentation, I would just like to ask you one question. So at different in different slides, you have mentioned the units somewhat differently. In some slides, you have mentioned nanogram per ml, in some microgram per ml, in some slides, international units per liter. So are these interchangeable, or what is the standard that we need to use?
Usually nanogram per ml is given as unit, sir, in the laboratory investigations. But some of the units which I came across in the literature is what I have depicted. Uh,
So is it
not
same?
sure.
Because then that might be problematic, you know.
It wouldn't be the same. I think we need to just see. I will just check back and I'll inform.
Okay, fine. Uh, Now, people have directly jumped to, when you talk of hyperprolactinemia, giving cabergoline or bromocriptine or something like that. What about adding aripiprazole? Does it help
Uh,
clinically?
Yes, sir. Many of the times, because if the presentation and even if the serum prolactin levels are very high, along with the clinical signs and symptoms, there is a good scope for substituting the offending antipsychotic. So we can cross taper the offending agent, and we can slowly increase the aripiprazole, which is usually the prolactin sparing antipsychotic, what we refer to as. So even in our clinical practice, I have noticed that there was a patient who had this kind of galactoria, and by substituting I got a good result with the aripiprazole. Yes.
Because our main concern is when we have patients who are on antipsychotics mainly, and sometimes with other categories of psychotropic medication that we use, hyperprolactinemia occurs. Now, the point is that we need to treat that condition. For us, hyperprolactinemia is, let's say, problem 1B, the main problem being the condition that we are treating. So we'll need to give something. And actually, if you look at I mean, what you're saying, any category of drug can cause changes in prolactin levels. So whether do you think that reduction of an antipsychotic on which a patient is stable? Stable means completely stable. I mean, there are no ups and downs in the basic presenting phenomenology. So basic phenotype, the symptoms are very well under control. Now there is this hyperprolactinemia. So what would be your suggestion? Add a low dose of aripiprazole, or kind of cross trip a little bit, because if let's say patient is very stable on 10 milligrams of olanzapine and something like this happens, are you going to, kind of disturb or rock a steady boat?
Usually, if the patient is steady, I wouldn't want to alter the dose, or usually would substitute with the equivalent dose of the counterpart. And in this case, if the patient is having serum elevated serum prolactin levels, but she is able to manage a little bit of galactoria, which is, and if she is near term, I think I would retain the doses. Otherwise, substitution is what I would go for, sir.
Yeah, Rukshida, you were saying something.
So personally, I know the evidence suggests adding aripiprazole will be prolactin sparing, it'll help. But if a patient has in my clinical experience, it's not really helped that much.
Okay.
I would start with aripiprazole, hoping that it is prolactin sparing, but if they're going to have hyperprolactinemia, they will also have hyperprolactinemia with aripiprazole as well. And adding aripiprazole to olanzapine or another antipsychotic hasn't really helped, in at least in my experience. So I've been a little disappointed with that evidence.
Okay. Because there is a group of gynecologists who are very scared of aripiprazole, because when somebody is on aripiprazole, they'll say, this needs to be kind of stopped or reduced because it leads to lactation failure. So they are quite unhappy some of them are quite unhappy when we give aripiprazole.
Because lactation failure does happen with aripiprazole.
Yeah.
The mechanism is not dopamine and dopamine related mechanism. It is due to something else, but it happens. I have had too many patients of lactation failure on aripiprazole. It used to be my favorite drug once, and as I learned from my own mistake that should not be any favorite drug.
There should not be
There should not be any favorite drug.
favorite. Okay. So that was one thing. Another question that comes is, can we neglect galactoria at lower prolactin levels if reproduction is not the concern? I think we have kind of answered this kind of questions earlier on. Rukshida, you can take the next question.
Uh, again, there's no name here, so we don't know. As a psychiatrist, what should we be wary of if our patient is put on cabergoline symptom-wise, and if aripiprazole is used, is there a specific dose range that should be used to lower the prolactin levels?
So yes, when it comes to aripiprazole, I think usually the doses would be between 10 to 20 mg. And regarding cabergoline, I don't have much experience as such. Theoretically, I would be able to answer. So I would request any of the moderators to help us through this.
I think we discussed cabergoline. So
Yeah.
this is what they usually do. I don't think cabergoline does anything really problematic for us in the doses which it is given. So that is not really a problem. The question that has also come up is that, can the level or a range of, means when you do a serum prolactin level, is there a level or range which will indicate if the hyperprolactinemia is drug induced or because of another pathology like an adenoma?
Drug induced, like usually I've mentioned in the risperidone and metoclopramide, can lead to more than 200. I think there could be, we can suspect when it is more than 200 in case of drug induced. Yeah, that's what the reference.
I mean, so roughly, can we say that, if the levels are in few hundreds, it is more likely to be a non-adenoma kind of, or a non-primary pathology of the pituitary or the hypothalamus?
Yes, sir. Once again, if it is ranging between hundreds to thousands, again, the issue of macroprolactinemia can seep in, and we need to differentiate there. Otherwise, I think if it is usually hundreds, and if it is, and we are sure it is drug induced, and may not be looking at a macroadenoma or something like that. Yes.
Okay. When would you recheck prolactin levels after starting, let's say, aripiprazole to treat hyperprolactinemia? When would be the repeat?
Repeat could be ranging between 8 to 12 weeks of starting. So that's how we can track prolactin. Yes.
Okay.
As cabergoline side effects are concerned, some women, especially because most of the times it's used in women, will have nausea. Some of them will also have giddiness, and they cannot tolerate the cabergoline at all. So in those cases, we just lay off the cabergoline entirely, and especially if there is no symptoms as such. But beyond that, no symptoms in that sense.
Okay. Okay. So unless there is a tolerance issue, usually not that big a problem. How does hyperprolactinemia interact with other endocrine disorders in psychiatric patients, and what are the implications for treatment?
Yes, regarding thyroid releasing hormone, that is TRH, has an increasing effect, I mean, the positive effect on the increase in the serum prolactin. So, as a primary hypothyroidism, there will be the increase in the serum prolactin levels. So, if we are looking at only increase in serum prolactin, we can also check on the TSH. And if TSH is the main culprit, then we can treat thyroid disorders, but the presentation also could be mood disorders in case of hypothyroidism. So the increasing serum prolactin can also lead to some amount of mood symptoms when it is compounded with the primary hypothyroidism. Yeah.
Okay.
Yes, sir.
Any comments on prolactinomas presenting with cognitive symptoms? You gave a list of the common symptoms, the common neurological symptoms associated with prolactinoma, but any cognitive symptoms as well?
I think you can only lead to some of this endocrinological and mass effect. I'm just not aware of this cognitive side effects.
Okay. Fine. Somebody asked whether it's possible to get the presentation. Of course, this will be uploaded onto the YouTube. There's a channel, Brain on Wednesday. So please visit YouTube, visit this channel, like, subscribe. The more views we get, the better it is for all of us, for people who have logged in and people who would want to visit the presentations at different points in time. We will get the YouTube link in a couple of days, so we'll post it. Dr. Rajkumar does that in the next few days. Dr. Rukshida, where is she gone?
I think she's gone off the video.
No, she is there.
She's there, but she has muted herself.
Muted herself.
Yeah. Rukshada, you are muted, you are needed.
Yeah, so yeah, Dr. Rukshida. I think we have been through the questions. We would like your comments on, or anything else that you would think.
That cognitive the effects, I think in case of prolactinomas, yes, I think it can lead to maybe some amount of disturbances in the short-term memory. I think I'll just get back. Just refer.
And short-term memory and
Um,
think about prolactin, what it does in brain.
is
So-
a visual memory or something?
One of the things that you mentioned is that in a physiological increase in hyperprolactinemia, physiological reason was seizures,
Yes.
post seizure. So there had been some talk of when somebody, true seizure and pseudo seizure. One of the differentiating thing is that if you can take a serum prolactin, uh, and if it is raised, then it's a true seizure. If it's not raised, not a true seizure, something like that. So how valid that is? And for how long? I mean, after, let's say, even if there is a increase in serum prolactin level after a seizure, how long? I mean, what till what level does it go into hundreds or thousands? And if whatever level it is, how long does it remain elevated?
Usually post seizure, it can vary between 50 to 100, and it can last up to few hours only, and it may not be the case in all kinds of seizures. So usually all seizures may not be associated with increase in the serum prolactin. So it's not a specific marker to differentiate between a true seizure versus a pseudo seizure. Yeah.
Okay. Yes. Yes, Rukshida.
No, I think we're done. I think very good presentation, good discussion. Unless Bhaskar has some more points for us to think about and chew on later on.
No, at present, I'm happy with the talk, and I'm happy with the overall thing, the way it's going on. Probably we would have some more news to share in coming month. But at this moment, I'm happy.
Okay.
All right.
Okay. Yeah.
Thank you. Over to Dr. Rajkumar.
Thank you, Dr. Vaibhavi. Thank you, Rukshada. Thank you, Malay and Bhaskar and all the participants. We also thank our knowledge partners, Alchem CNS Division. Good night to all of you. We'll meet you again in a fortnight's time. Bye then.
Bye.
Thank you all.
Bye bye.
Bye bye.